Hello everyone, welcome to Pediatrics by Dr. Anand, and this session we're going to talk about asthma, questions on asthma, important 100 questions which are important for IAP quiz, which is important for MBBS, MD, super specialty, whichever exam you say, it is important. So coming to question number 1, what is GINA? That was the first question. What are GINA guidelines? The basic questions for asthma we have taken from GINA guidelines, Nelson's, as well as from OPGA 9th edition. So global initiative for asthma. Very good, Megha. That is the first answer. The GINA guidelines, the first, what is GINA? A basic MBBS question to the examiner ask you, what are GINA guidelines? So global initiative of asthma. In that one, we have given asthma plan and the whole treatment is there. So global initiative of asthma is the GINA guidelines. PDF of this file I have already shared in your WhatsApp group. Okay. Yes. So let me see. So this is a GINA guideline definition. Asthma is defined as dash inflammatory disorder. It is a chronic or acute inflammatory disorder. Very good, very good. So Ramya has answered very nicely. So very good. So please remember that this asthma is a very important. It is a chronic inflammatory disorder of the lower airways. That is very important. It is a chronic inflammatory disorder of the lower airways, characterized by, very important, characterized by episodes of variable reversible airflow obstruction with airway hyperresponsiveness manifested as recurrent wheeze or cough. Okay, simple definition. Hi Elizabeth, I'm happy you have come. Last quiz you were not there. So it is a chronic problem of the lower airway. That's it. It's a GINA guideline definition. Question number 2 over. Okay, so question number 3. Yeah. So see, there is something known as, now this is important. So can anyone tell me what is a enhancer? Now here extra points we need to know. What is a enhancer? What are the triggers in general? And what is a inducer? Okay. So who will tell me what is an inducer? Any idea? So Rohan, what is the inducer? Like we say, these are the inducers. Inducers means what exactly? Can anyone help me out? What is an inducer if I talk about in asthma? Okay, okay. So there someone is answering aspirin. So please remember, see, inducer. Okay, inducers. Inducers, very important. They generate, the inducers. They generate an immune response. Inducers are the one who generate an immune response. Okay, in pertaining to what? For example, of course, through a dust mite, maybe through a cockroach, maybe through a grass pollen, maybe. Are you understanding? So inducers are the one which generate immune response from something. So question number, very important, question number 3, that's what it's talking about. Which of the following is an inducer? So according to GINA guidelines, option number 1, dermatophygoids, this one. So this dermatophygoid is nothing but dust mite. The other name for this is this only, dust mite. The first option A is nothing but I'm talking about dust mite. Option number B, Blatella germanica. So that is nothing but regarding talking about a cockroach. These are the various inducers which you need to know. Okay, number 1 is dust mite. Second, this Blatella is nothing but the cockroach. And this one, the option number C, Sorghastrum nutans. This is nothing but I'm talking about the grass pollens. It is just the other names you should know. So dust mite through the cockroaches or through the grass pollens are various inducers which generate an immune response. That is the first thing. Okay, and very important, what are the enhancers? Can anyone name me some enhancers? Rohan, what are the enhancers we can think of if I ask you in asthma? What are enhancers? What are the examples? So you should know that. See, enhancers are nothing but enhancers. They aggravate this response. They aggravate this response on repeated exposure. Try to understand more, try to cram less, try to understand. Okay, so enhancers are the one they which aggravate the response. For example, a viral infection. For example, any diesel particles even. And last but not the least, for examples, any comorbid conditions. comorbid conditions. These are the enhancers basically. If I have a comorbid condition, example, rhinitis, sinusitis, so it's basically it will aggravate the response. Okay, so that three things important you need to know. Inducers are the one which generate an immune response. Examples of the inducers are there in question number 3. Okay, then we have enhancers which aggravate aggravate the response on repeated exposure. Examples are through viral infections, could be because of diesel particle, could be because of comorbid conditions. So now what Rimsha is talking about, she is talking about the triggering factors. Okay, what are the triggers? What are the triggers? Triggers basically, they are the agents that stimulate the symptoms in a child. They are the agent that stimulate the symptoms in a child. PDF of this file I have already transferred you. You have it. So triggers are the agent basically which stimulate the symptoms in a child. Examples could be exercise, could be dry or a cold air. Very right, Rimsha has said, because of pollution, because of tobacco, or even because of strong fumes of the perfumes. Even asthmatic patient, they don't like the perfume smells because that's like a triggering factor, and their symptoms will come. Are you understanding? So these three basic things you need to know: inducers, enhancers, and triggers. This question has come, you should know. Question number 4. So that's what, which of the following is a trigger in the bronchial asthma? I have already told you. Trigger basically, see, in a trigger only A plus B is correct. The cold air, dry air, environmental, this one factors, tobacco smoke, pollution, could be because of methacholine, histamine, strong perfumes, all those things are triggering factor. And according to GINA guidelines, this comorbid condition, it is not a triggering factor. They have said it is more, it's like an enhancer. It is more like an enhancer. Very good. Very nicely people have written. Very good. Okay. Very good, Rohan. Perfect. Okay. You'll be a very good doctor. So what is the WHO cutoff of the fast breathing? WHO cutoff of fast breathing in a 5-year child? Even my grandmother also can answer this question. It's a very old, repeated question. So Rohan, what is the WHO cutoff of fast breathing? So you know that the WHO cutoff of the fast breathing are, number 1, yeah, very important. So in the 0 to 2 months of life, any baby having respiratory rate more than 60 cycles per minute is nothing but, I will say, sir, this baby is having the, what you call, fast breathing. Okay. So Tushar is asking where to find the PDF. Tushar, the PDF is there in our WhatsApp group of the asthma students group. If you are there, well and good. If not, you can WhatsApp me. Okay. So 0 to 2 months baby having respiratory rate more than 60 cycles per minute, I would say this is a WHO cutoff of the fast breathing. Then 60, 50, 40, 30, that is the mnemonic. So then we have 3 months to 1 year, it is more than 50. 1 year to 5 year, it is more than 40, and more than 5 year, it is this more than 30. So that is fast breathing. Very good, Rohan. Very good. Very nicely you're answering. Very good. So that is the WHO cutoff of the fast breathing. Very simple question, but yet they have asked questions multiple times. You should know this. Okay. Very good. Spotter. Yeah. So now this quiz I have made with lot of thought process, just not to add theory knowledge. I wanted to put more pictures, how exactly you will see, right? Right. So very good. So Rohan, what do you think? Swati? Yes, very good. So this device, okay, this device is nothing but peak expiratory flow meter. That is the first point. Okay, and in this peak expiratory flow meter, what do you check? Rohan, what do you check in this peak expiratory flow meter? I check the peak expiratory flow rate. Yes or no? This much you understand, right? This is nothing but peak expiratory flow meter. I will tell the patient to blow it, and these are the markings. If you can see, I will see where the patient is landing into. Okay, yeah, after a normal respiration and a deep inspiration, like that. Okay, so peak expiratory flow meter. With every question we are passing, we'll try to add on more and more points. Very good, Elizabeth. Very good. Okay. Next is the spotter. Yeah. So what is this? Any idea? Any random guesses? Yeah, Sameer is very right. Today morning only on YouTube, I have made a video on how to use a metered dose inhaler, which is very important for you. You must watch it later if you get time. So this is nothing but M MDI. Elizabeth is very right. MDI is nothing but metered dose inhaler. That is the first point. This metered dose inhaler has three parts. Can you see this upper part? Rohan, what do you call this upper part? This is, what is this? What I have put inside this thing. Very good. So Rimsha is answering. This is nothing but canister, number one. Number two, what is this white? Any idea what is this white? What do you call it? Yeah, Swati is very right. It's nothing but actuator, or a plastic holder, or a plastic holder, I would say. In the book it was written plastic holder, also it was written actuator. Actuator is the one which puts this machine into action. Like I need an actuator, I'll put my canister, I'll put a pump. So actuator is something which puts something into motion. That is known as actuator. Okay, and last but not the least, Rimsha, what is this? Any idea? It's nothing but a cap. Swati is very right. It's nothing but a cap, right? Simple. So all these three things together, they form nothing but the metered dose inhaler. This quiz I have made with a lot of thought process, so that clinical acumen is important. Even you become MD physicians also, MD pediatrician also. This is something you have to be explaining to the patient in your daily practice. So you should know this part. Okay, next. Yeah, so this is nothing but meter dose inhaler. Yes, Rohan is right. Okay, now choose the best option. Yeah, so now we are coming to more extra points. Okay, so what is this? So this I know, Rimsha, this is nothing but, yes, it is metered dose inhaler. Now what is this? And around the mouth, what is what? Yeah, Megha is right. So around the mouth, we have nothing but known as the mask. Very important. Annapurna, hi, welcome to Pediatrics by Dr. Anand. I thought you were not there in the class today. Yes, so it's nothing but the mask. Okay, and then what is this white? What is this? It is nothing but the spacer in the center for a better aerosol therapy, for a better drug delivery, for better whatever you say, for better in children's also, and all that, right? Basic I'm telling you, which is very important. Okay, next. This part is over. It's nothing but the spacer over. Yeah, so okay, Annapurna, hi, no problem. So peak expiratory flow rate. Yeah, so now we have to come, to little more definition and little more points. So yes, so this is nothing but very important, a very important image. Child is showing you how she is using a peak expiratory flow meter, and what you will check in the peak expiratory flow meter, you will check the peak expiratory flow rate. That you will check. Okay, basics are very important. You should be very crystal clear. Even till today, few of my MD pediatrician friends also are confused with this, so you should know it. Okay, very good. Okay, coming to the next lot of questions. So this is nothing but peak expiratory flow rate is the person's maximum speed of expiration as measured with the peak flow meter. That's very important. Rimsha is very right. This is nothing but person's maximum speed of expiration, peak expiratory flow rate. Okay, na? I hope this much you are able to understand. I'm trying to be as simple as possible. Okay. Yeah, so now coming to the next set of important questions as well as important points. So what is FEV1? Can anyone tell me what is FEV1? Any random guesses? Rohan, what is FEV1? What do you think? What is the definition of FEV1? Okay, so I'll tell you. Yes, very good. So now this is something we have to understand. See, there is something known as FEV1 and there is something known as FVC. Okay, I'm telling you in a very simple basic language you should know. FEV1 is nothing but forced expiratory volume. Forced expiratory volume in the first second. Okay, FEV1 is the forced expiratory volume in the first second. Means in 1 second, how much you can expire out forcefully. Are you understanding? That is known as FEV1. In the 1 second, how much you can expire out forcefully. Now, if you can see this graph, if you are able to understand, can you see that? So this one, FEV1. So this is nothing but time in seconds. And in 1 second, how much I'm able to expire out. That is FEV1. Okay, that is the first point. And normally around 97%, we can expire in the first second. We'll tell the patient to deep inspiration and then zor ke we have to take it out. Okay, that is the FE1. What is FVC? FVC is nothing but forced vital capacity. What is forced vital capacity? Forced vital capacity means after each deep respiration, how much we can forcefully expire. But here I'm not talking about the seconds or in the first second or something. I'm just telling after a deep respiration, how much we can forcefully expire. Okay, that you should know. Okay, and in 1 second is the FEV1, and in general, how much I can forcefully expire is forced vital capacity. Okay, this much I hope you're able to understand. In this graph also, if you can see, this is nothing but forced vital capacity, and this is nothing but the forced expiratory volume in the first second. So as you can see in the graph, this is the time and this is the volume. So that's what. So this is nothing but the FEV1 and this is nothing but the FVC. Now there are two problems. One is known as, where should I write it? Okay, one is known as obstructive lung disease and other one is known as restrictive lung disease, right? If this much you understand, you can do anything in life. So question number one, can anyone name examples of obstructive lung disease without seeing the PDF file which I have shared with you? So very good, Megha is right, very right. So we have COPD. First, these examples are very important, okay, very important. So COPD could be, bronchiolitis also, bronchial asthma also, could be bronchiectasis also. Are you understanding? So that is, these are the examples of COPD, emphysema, asthma, bronchiectasis, and even bronchiolitis. These all are obstructive lung disease. Very good, Samir. So remember, if I'm having asthma, okay, if I'm having asthma, and if you tell me to blow in that peak expiratory flow meter, you tell me to blow in this 1 second, like you tell me to blow, right? So naturally, if I'm having asthma, if I'm having a obstructive lung disease, my forced expiratory volume of the first second will increase or decrease. Any idea? It will decrease. Okay, because I'm having asthma, I'm having some airway problem, right? So the forced expiratory volume in my first second will decrease, but at the same time my force vital capacity will be the same. Okay, force vital capacity will usually affect in the restrictive lung disease. Restrictive lung disease means where there is reduced expansion, where there is reduced expansion of the lung parenchyma. I'll tell you, Dr. Hamid, why. So restrictive lung disease are the ones with reduced expansion of the lung parenchyma. The examples are, yes, very important, interstitial lung disease. The example, if I'm facing any fibrosis, if I'm having sarcoidosis, yes or no? Or if I'm having chest wall neuromuscular disease, chest wall neuromuscular disease. So Hamid, try to understand, if I'm having fibrosis in my lung, then what will happen? Neither I will be able to blow nicely in the first second, as well as my total forced vital capacity also will be compromised, because I'm having fibrosis. I have problem in the expansion of the lung parenchyma. Are you understanding? So that's what I'm trying to say you, that force expiratory volume in the first second as well as force vital capacity decreases in restrictive lung disease, whereas in obstructive, there is a problem in the first second, but in general, the lung capacity is not affected. In the obstructive lung disease, if I'm having, I'm having cough only. Did you understand? That is a basic concept. So obstructive lung disease, remember, the FEV1 upon FVC ratio decreases. FEV1 upon FVC ratio decreases. Okay, because if the nominator decreases, the ratio automatically decreases. And remember, the lung capacity is not affected in obstructive lung disease, whereas in restrictive lung disease, there's a problem in the expansion of the lung parenchyma, example fibrosis, sarcoidosis, and all those things. So everything will affect. Even my first second, that FEV1 will also affect, and my force vital capacity, the whole capacity also will affect. So the questions that the examiner had asked was the ratio, what happens to the ratio? So in restrictive lung disease, the ratio will be the same. Why? Because the nominator is also decreasing and the denominator is also decreasing. That is why ratio becomes the same. Whereas in obstructive lung disease, the nominator decreases, but the denominator is the same. So that is why the ratio decreases there. And less than, the FEV1 upon FVC is less than 0.8. Okay, FEV1 by FVC ratio is less than 0.8. That's another NEET PG and AIMS question, which is seen in obstructive lung disease. Through this webinar, this much only I'll explain. Okay, if not, you come, I'll explain you again. That's it. So that's it. So question number 12 in a view of pointer A. What do you think? So this is a normal radiograph. See, this is the pointer A, which is telling a nicely FEV1 and a nice FVVC. Are you understanding? So this is nothing but what do you call it? It's a normal radiograph. And also, if we talk about here only, if you want to talk about the graph, okay, of the graph of the obstructive and restrictive lung disease. So please remember, in the obstructive lung disease graph, what will happen? See now carefully, okay? So this is the first second, like this. The first second, this is the FEV1, and this is the FVC. Yes or no? This is the normal graph. This is the normal graph which happens. Okay. Now in obstructive lung disease, as I have told you, FEV1, the first second problem will be seen, but the whole vital capacity will remain the same. So my graph usually goes like this. Okay, because the force vital capacity is the same, but at the first second I'm having issue because I'm having obstructive lung disease, and that is how a graph will look like for a obstructive lung disease. Are you understanding? Whereas restrictive lung disease, so what will happen in restrictive lung disease? Again, a graph like this is my first second ka parameter. The down part is, this is our time in seconds, and here is the volume in liter. Okay, so normally again, first second, nicely I took a breath and nicely I went down. This is the normal. This is normal. Now what happened in restrictive lung disease? So restrictive, I told you, both things will be affected. Annapurna is very right. So my graph will go like this and like this. Are you understanding? So this is also affected and this is also affected. So this is a graph very important of a restrictive lung disease, and this is a graph of obstructive lung disease. This is a very simple but yet very meaningful slides, very meaningful questions. Examiner always ask you why this ratio decreases, why this ratio increases. Name some examples. A patient of fibrosis of lung, what do you think? It's obstructive or restrictive lung disease? So you'll tell them, sir, it's more looks like a restrictive, because whenever there is a reduced expansion of the lung parenchyma, that I should think of a restrictive lung disease. Examples, fibrosis, sarcoidosis, and all. Okay, done. That's it. So question number 13 is that only what is FEV1 in this graph. So we have already covered in 1 second how much we expire forcefully. That is force expiratory volume in the first second. Then next question I had made was, what is FVC in the image shown below? FVC in the image shown below is nothing but same. I have already covered. Forced vital capacity means after a deep respiration, how much we can forcefully expire. That is forced vital capacity. I'll just take water. Question 15, we have already covered the examples of obstructive lung disease. This we have already covered. And then again, the examples of restrictive lung disease also, fibrosis, sarcoidosis, chest wall neuromuscular disease, and interstitial lung disease. All these are even congestive cardiac failure also. We can land up into restrictive lung disease. This also I have already told you. Okay. We have covered, yeah. So this graph interpretation already over. This one, the black one, this is nothing but a obstructive lung disease, whereas the other graph I told you, this more looks like a restrictive lung disease. Nicely explained and nicely written in the books also. No PDF I have already shared with you. Okay, ratio, yes, the ratio of the forced expiratory volume at the first second upon FVC in an obstructive lung disease is less than 0.8. Is less than 0.8. Again, an exam question, and we have already covered that. Very good, Rohan. Very nicely you have written. Okay. Okay, so now coming to the next lot of questions. Which of the following is a short acting bronchodilator? That is the next slot of questions. So we have something known as SABA and we have something known as LABA. Yes or no? SABA is nothing but short acting beta 2 agonist. For the newcomers, I'm writing line by line so that at least you are, you should know the terms. You should not go above your head. Okay. So SABA is nothing but short acting beta 2 agonist. In that also we have selective and non-selective. So very important, this picture only. So very important, you know that terbutaline and salbutamol, they are the specific beta 2 agonist, whereas adrenaline is a non-selective beta agonist because it has works on alpha also, beta also, everywhere it works. So selective ones is the terbutaline and salbutamol. Okay, and okay, beta 2 agonist. So can anyone tell me, Rohan? So what do you think? This beta 2 receptors कहाँ पे act करते हैं? What do you think? Beta 2 receptors act on what? Any random guesses? Where does it act? It acts on the heart. It acts on the lipid profile. Where does it act? So you know that it acts on the basically smooth muscles. Annapurna has a very good answer, smooth muscles. So what does it cause? Beta 2 agonist, if I'm giving, will it cause smooth muscle relaxation or smooth muscle constriction? So very important. So smooth muscle relaxation. Very good. So beta 2 agonist called smooth muscle relaxation. Very good. Okay, an extra question if I ask you, beta 1 कहाँ पे होते हैं? So Rohan, what do you think? Annapurna, where is beta 1 normally? So beta 1 is in heart. Very good, very good. So Ramya, in heart, what does it cause? If I'm giving a beta 1 agonist, it will cause what? Any idea? Any random guesses? What do you think? So it cause increase in the heart rate. It cause tachycardia. Very good, very good. Okay, coming to alpha 1. So Megha, alpha 1 कहाँ पे होते हैं? Where does alpha 1 receptors are there and what does it cause? Any idea? Any random guesses? Alpha 1 acts on the okay, normally alpha 1 is in where, like, it does it cause so very good, Samir is right. Alpha 1 causes vasoconstriction. That is why it increases my BP. That is why in hypertension I give alpha blocker. Alpha 1 causes vasoconstriction, it increases the blood pressure. That is why we give alpha blockers in hypertension. So Ramya, name some alpha blockers. Any random guesses? This is an extra question I thought of asking you. Name some alpha blockers, fast. So very good. Raval is answering. Prazosin. Annapurna, next. Terazosin. Then Rohan, doxazosin. Very good. Then Annapurna, tamsulosin, and last one, tamsulosin, and one more, fast, Annapurna, what do you think? And phentolamine. Okay, phentolamine. These all are the alpha blockers. अच्छा, alpha 2 कहाँ पे होता है? Any idea? Elizabeth, where is alpha 2 and what does it does? Alpha 2 is in, where is alpha 2? Alpha 2 has what? Central and peripheral action. Fast. Pharmac is not coming this time. In PG exam, Pharmac doesn't come, or it comes. Any idea? So alpha 2, anyone? Annapurna, you're not answering. So alpha 2 centrally, it causes vasoconstriction, but peripherally, it causes vasodilatation. Okay, basics are everything in life. You need to know them. Okay, and so one more we left. Beta 3. Where does beta 3 acts? Annapurna, what do you think? Beta 3. Beta 3 acts on Rohan. What do you think, Samir? Yeah. So beta 3 acts on the fat, basically lipid, and it causes lipolysis and thermogenesis. Very good. Okay, perfect. Okay, next coming to this part, Saba and Lama. So short-acting beta-2 agonists, the selective ones I have already told you, terbutaline, salbutamol. Non-selective is adrenaline. So can anyone tell me anything other than this? So Annapurna, anything other than this? Can you name any short-acting beta-2 agonist? Any random guesses? Put your answer in the comment section, please. So we have something known as levosalbutamol. Yes or no? So albuterol is nothing but salbutamol. So levosalbutamol. Then we have nothing but metaproterenol, metaproterenol. Then we have isoproterenol, and then even terbutaline already covered. Yeah. So are you understanding? So adrenaline, terbutaline, salbutamol, levosalbutamol, metaproterenol. This one more is there. PI, pi, buterol, and isoproterenol, terbutaline. These all are short-acting beta-2 agonists. Okay. So can anyone tell me, Annapurna, long-acting beta agonist? Any idea? Laba, anyone? Any random guesses? So Ramya is answering yes. We have formoterol. So we have formoterol. Very good. Salmeterol, meterol, very good, Elizabeth. And then we have indacaterol. These names you should know in general, so you should know. And olodaterol. These all are the long-acting beta agonists. Names you should know. You should know the names. Okay, chalo next then. This part already over. Question 21. A 5-year-old child with asthma, doctor told that the nurse that the child is to be given a bronchodilator, which is supposed to be given subcutaneously. So can you tell me which is the bronchodilator in general options subcutaneously available with us? So yes, very good. So even adrenaline also subcutaneously you can give. Even terbutaline also you can give subcutaneously. So that is why the answer is A plus B, adrenaline and terbutaline. Very good. Next question. Okay. A 5-year-old diagnosed with bronchial asthma, he's planned to put on long-acting beta-2 agonist, which has an action which lasts for 12 to 24 hours. So what are the options available? So already we have covered the long-acting beta agonist. Of course, the salmeterol, formoterol is there in that. Other also have told you these all are long